I am very pleased to introduce our first plenary speaker of the FMEC 2018 annual meeting. The really nice and easy thing about introducing an amazing speaker with a really long bio is that I can say, I really invite you to read his bio on the app or in the program, because it doesn't help this whole situation for me to repeat all of it. But I think there are a couple of key things that Dr. Michael Fine wanted us to focus on, which is he was a community organizer before he was a family physician. And he has dedicated his career to really marrying those two concepts and looking at healthcare and health in the context of the community. So I think that's good enough, don't you think, Michael? Yeah, okay, Dr. Michael Fine.
Thank you, Amy. It's wonderful to be here among so many friends and colleagues. I look around the room and think of the people I know who are here and the work you do every day. It's, you have my endless thanks and admiration. I'm still a public health guy. So one other thing that I want to do as I try to shake you up a little bit tonight is to get you on your feet once in a while. And one of the things that I think everybody needs to be on their feet for is for Larry Bauer, who pulls this together again and again and brings us together again and again and makes community happen. Larry. Let me talk a little bit about my personal story. I was born in the Bronx and grew up in New Jersey, actually around the corner from Neil Kalman, who many of you know. I don't know if Neil's here tonight. And I learned as my growing up from my grandfather that it's immoral to profit from someone else's misfortune. I was the son and grandson of immigrants and have even an illegal immigrant in my past, and think about that as I look at the world. I spent some time as an organizer in the Bronx, in the South Bronx, not far, I suspect, from where Dr. Ford grew up. And his notion of hitting the boiling point really hit home with me because of what I saw not only in the Bronx, but then in my time in the National Health Service Corps in the 5th poorest county in the United States. In the Bronx, I saw a place that had been abandoned by medical care. In Sneedville, Tennessee, in that 5th poorest county in the United States, I saw a place where there were 2 physicians who practiced in a tiny little hospital and made sure that they did okay when the people of the county got poorer and poorer. They worked out a system so that they got paid, but people in the county struggled, so that those 2 physicians had each 7,000 acres and herds of purebred cattle, but the county called Hancock County was 66% unable to read and really struggled day after day after day. And that really made me start to question what it was we were doing and how we're doing it. It got me to see for the first time, unfortunately, that we often have a market, not a system, and to be able to think about what we need to do to change that. Now, I was lucky to meet a couple of fairly amazing mentors. And I want to start by telling their stories briefly because of how important they are and what great examples they are about what we can do together. Dr. Bernard Lown is 97 years old and lives outside of Boston. He was the inventor of the defibrillator. He invented modern CCU care. He initially described Lown-Levine-Ganong syndrome, the second pre-excitation syndrome after WPW. He's helped start Physicians for Social Responsibility. He was a world-renowned cardiologist in the 60s and 70s when he realized that if there was a nuclear war, that none of his cardiology would be any good. So he teamed up with Dr. Yevgeny Chasnov, and they started a process of organizing. They wrote papers, they gave speeches, they talked to patients in exam rooms, and they found 400,000 other physicians to do the same kind of work. But the time they were done, they had forced nuclear disarmament. And for that work, Dr. Lown received the Nobel Peace Prize in 1985. A physician using community organizing and using healthcare to change the world. Jack Geiger is, I think, 93 or 94. He was a science affairs writer before he went to medical school. He was also a founder with Dr. Lown of Physicians for Social Responsibility and of Physicians for Human Rights and of the Medical Committee for Human Rights. He came out of the civil rights movement. He went and spent some time in Fulola in Africa, in Namibia, learned about community-oriented primary care, came back to the United States, started the first 2 community health centers in the United States, one in Columbia Point in Massachusetts, one in Mound Bayou, Mississippi. And out of that work grew 1,400 community health centers at 9,000 sites that take care of 26 million Americans, almost a tenth of the population, and always focused on making sure that healthcare was a way to address health disparities and social inequality, and kept a focus on social determinants of care before we had that language. As some of you may know, when he got to Mount Bayou, what he found was a place where the most prevalent medical condition was malnutrition, and he shook things up a little bit when he started prescribing food, which, when he got into trouble, he said, oh, well, the last time I checked my textbooks, the specific therapy for malnutrition is in fact food. Contrast that, well, let me talk for a second about HIV/AIDS, and contrast the work of Dr. Lown and Dr. Geiger with the situation we have with HIV/AIDS. Highly active retroviral therapy was discovered in the United States in 1996, 22 years ago. We learned shortly thereafter that therapy is the single, or is as effective at prevention as any vaccine we have. Directly active retroviral therapy, once people are initiated and maintained in care, keeps people from transmitting disease. The CDC in 2003 recommended that every American 13 to 64 be tested for HIV. And if you think about it, if we had followed that advice, there would be no more HIV transmission today. There would be no more HIV transmission today because everyone would be identified, begun on therapy, and maintained on therapy. We, however, are in a country where we have no healthcare system. So we have no way to organize the testing of all the people 13 to 64. We have no way, once tested, to get people into treatment, and no way to know who's maintained in treatment. Between the years 1996 and today, over 500,000 Americans have contracted HIV because we don't have a healthcare system, even though we've had the science to stop that epidemic, and we've had that science for 22 years. This isn't a problem of science, it's a problem of system and system organization, and it's a problem for all of us. In fact, what's called the U.S. healthcare system is really an expensive failure. We had 80,000 deaths last year, preventable deaths from influenza in a year when we went from about 50% of the population immunized to a 44%. We have 80,000 deaths a year from diabetes, which, if you begin to think about it, is essentially a preventable disease. We have 72,000 iatrogenic deaths a year from colon cancer. From drug overdoses, and 50,000 preventable deaths from colon cancer. Colon cancer is almost entirely a preventable disease, and those deaths happen only because we don't get everyone colonoscopy. Only 50% of the population gets colonoscopy. We have 20,000 deaths a year from hepatitis C. That's a disease for which we have treatment, and again, all we lack is universal testing and getting people treated. We have 37,000 deaths a year from gun violence, and 7,000 deaths a year from HIV/AIDS, 250,000 deaths a year from medical error. Itself a pretty scandalous situation that's mostly from overtreatment. 800,000 deaths from heart disease and 82,000 deaths from alcohol, much of which is preventable if we only had an organized way to get that prevention done. And to make it worse, health in the U.S. costs twice what it costs in other countries. We waste somewhere between $1 and $1.5 trillion a year, which comes out of the public pocketbook as profit. 1.5 or $1 trillion a year is more money than I can imagine. It's about 6% of the gross national product. It's more than the gross domestic product of Switzerland, of Turkey, of Saudi Arabia, of Argentina, of all countries except for 16. It's so much money that it's equal to the entire student loan debt of everyone in the country, only we waste that much money not once, but every single year. It's actually enough money to pay for the education of 7.5 college students, 7.5 million college students. College is more expensive, but not that much more. Which is twice as many kids as graduate from high school every year. It's money that should be spent on education and housing and community development and the environment, which turn out to be the things that matter for health, but instead that money is going into the pockets of profiteers and really impoverishing us all and making our healthcare and our health worse. What we have is a wealth extraction system, not a healthcare system. And all this money actually threatens democracy itself. 0.03% of $1.5 trillion is used for lobbying. That's $500 million a year. And that much money going into the pockets of lobbyists who use that money to try to influence legislators mean that the people who pay attention to, the people that the legislators pay attention to end up being people with something to sell, not the people they're supposed to represent. That $1.5 trillion is a roadblock to change because all the people who are collecting that money are not willing to give it up. And as it happens, it actually influences us a little bit because all of us end up being very well paid, and it's hard for us to look the other way. So we have a problem, a big problem, but it's time for us to stop admiring that problem. And it's time for us to find our boiling point and let ourselves boil. Most other countries provide primary care to everyone. Most other countries get this right. In most other countries spend 50% or less of what we spend and have outcomes that are much better. Infant mortality in most other places are a third of ours, even worse. infant mortality for African Americans in the United States is 9 times higher than the best achievable rates and 3 times higher than for the country as a whole. We have a market that permits this instead of making health care available equally to everyone. Our life expectancy is 2 to 5 years longer than most other places. In Finland, 40 years ago, they had the highest heart disease mortality in the world and one of the shortest life expectancies. They got themselves organized, they did a little guerrilla marketing, and they built one healthcare center for every 10,000 people. And now Finland has one of the longest life expectancies in the world, among the lowest infant mortality in the world, and it costs them $4,400 per person per year. In the United States, we pay $11,000 per person per year, more than twice as much, that we're not getting anything like the value. In Denmark, they organized primary care for everyone in the nation, and they closed half their hospitals because they just didn't need them anymore. There is a mound of evidence, and that mound of evidence suggests that if we provide primary care to all Americans, we will get way better outcomes at way lower costs and be able to use the money that's left over for the things that matter for health. If we provide primary care to all Americans, we will improve public health outcomes and reduce costs by 30% or more. And in order to do that, we need to build a healthcare system that cares for every single one of us. The what to do is easy to figure out. The how to do is much more of a challenge. You just don't change a $3.3 trillion industry by just asking it to change. You change a $3.3 trillion industry by building a national movement to change the United States. Now that sounds pretty daunting. It sounds daunting until you look back on our history and realize we are about building social movements. We came out of a social movement. Our revolution, our original, the American Revolution was a social movement to resist the tyranny of a monarchy. And after that came the abolitionist movement, which changed America. And after that came the movement for women's suffrage, which changed America. And after that came the anti-war movement that changed America, and the civil rights movement that changed America, though not quite enough, and then the movement for marriage equality. If we can do those things, there's no reason we can't build the movement for health care in America. And there's no reason that we can't do it, and there's nobody else to do it but us. So let me tell you a little bit about the community organizing process, because it's one thing to say, let's build a movement, and it's another thing to learn about how to get that movement built. As part of community organizing, the first thing people do is meet people where they are as they are. That's the very first step. And all of you, all of us, have the opportunity to do that every day in our exam rooms. The second step is to find and refine the motivating issue. There's a whole process of what's called issue development, where you suggest an idea to people who you've just met, see if they respond, try to get them to do something. If they don't do something, refine the idea, turn it over and over and over till you get buy-in. And I think all of us have had the experience over the last few years, 5 years, 10 years, 30 years, understanding that what's really beginning to motivate people is healthcare cost, the notion that we need an equal access to healthcare for all Americans, and that we need healthcare for people, not for profiteers. The third step is to bring people together and feed them, as we're doing tonight. And then fight a small winnable battle, win it, and then have a big party, which is, I think, what usually happens here sometime over the course of the weekend. Out of that work, out of building local interventions, local attempts, comes the work of building regional coalitions, what are called organizations of organizations, and then creating a statewide legislative strategy using demonstrations, strikes, petition drives, to open the political space for enabling legislation to pass, and at the same time building a national coordinating council, again, using demonstrations, strikes, petitions, all trying to open political space for change. It's not a 2-week exercise. It's a 10-year exercise or a 20-year exercise or a 30-year exercise. Think of the civil rights movement. Think of all the work and preparation that went into that movement. That's the energy and attention and commitment we're going to have to bring to bear if we're going to build a healthcare system for the United States. It is not going to change by itself. Somebody's got to change it. And the good and bad news is, I think the somebody is most likely to be us. What we're going to have to do is build small healthcare systems in every community, then build regional coalitions, then put together statewide advocacy and pass enabling legislation, build a national organizing committee. It's a lot of work, but we have a lot of people to rely on. There are 130,000 family physicians, students, and residents. There are 3 million nurses, many of whom are pretty ticked off. And then there are 10 million patients. We need 10 million patients of the 330 million patients, most of whom are pretty ticked off. But what we don't have is leadership, and I would argue that the leadership we need is right here in this room. So how do you do this? Well, first you start in your exam room, and you start to reflect on the cost of health care. I think it's okay to say to people, health care is costing you, or somebody's spending $11,000 a year for health care, $5,500 of that is unnecessary spend that ought to be in your pocket instead of in the pockets of the profiteers. It's okay to say to people that the salary of the CEO of the hospital is $3 million a year, or the salary of CVS when you go to buy a medicine that's incredibly expensive. That guy's making $12.7 million a year, and that's money that's being taken from your pocket and profit that's happening on your back. Then you can bring people together in your waiting room or in your living room to start to talk about this as an issue and try to figure out things to do. Different communities will do different things. Some communities already have community health centers. And for some of us, that means getting on its board. Some communities have not adequate access to primary care. And that means doing things like building multidisciplinary teams or working with home nursing services to make sure people in home nursing service, that patients can get coherent access to home nursing services. Every community is a little different. You find out what's going to work for your community by bringing people you know together. As I said, you can begin by organizing a multidisciplinary team for your community. You can move your own health care to a community health center and get on its board and start to build partnerships, because what we do models what other people need to do. Community health centers are a particularly ideal set of organizations because they already have community boards that have to be 51% consumers. And so it is possible for folks who know what they're doing to get on those boards and to get them moving. You know, again, those of us who know Neil Kalman really admire the work he's done with community health centers over the years, but we need to take that work and multiply it 100 or 1,000-fold. So there is real investment and involvement from people who are experts at healthcare in the community health center movement as we help it grow. You can bring the healthcare workers in your community together for hangouts, which is something we're trying to do in Rhode Island. Getting nurses and doctors and physical therapists and acupuncturists to talk to each other for the first time and get to know each other so that we can begin to work together with the communities we serve, because we certainly can't do this by ourselves. You can begin to take action to improve patient care, as the nurses in Massachusetts tried to do. And I think all of us ought to pay attention to job actions and and attempts to improve health care from every single healthcare union that exists. We ought to be able to support that work and ought to see if we can get people who are doing that organizing work to join us. You can begin to build statewide coalitions. In Vermont last year, there was a bill called Universal Primary Care introduced, with people all across the state worked for it, and it almost passed. I don't know if there's anybody from Vermont here tonight. All right. You guys got close. We tried it in Rhode Island. We didn't get quite as close as you guys did. But we ought to be able to do those things state by state. We ought to get different kinds of innovations passed. In Oregon, they passed legislation that increases the primary care spend. I don't know if there's anybody here from Oregon, probably too far. But those are the kind of innovations that need to happen and will happen when we get together and work together and actually get involved in the political sphere, not just the medical sphere. And finally, and this is hard, I think we need to tithe. We have been the economic beneficiaries of this system, of this market for a long time. We all do pretty well. That doesn't mean we do as well as we want, and it certainly doesn't mean we do as well as cardiologists do. But if we don't put up, if we don't participate, if we don't help fund this, it's not going to happen. This money needs to go to support organizing and organizers, so that we do the back work, the hard work of getting people to come together, sending emails, organizing meetings, sending out minutes, all the regular work of organizing. It's not hugely expensive, but if we don't fund it, it's not going to happen. And if we fund it, it will happen, and we can change this world together. So can we really get there together, you might ask? Can we really get this done? Well, I'm going to ask you the flip side question. Can you accept what the market has made? Can you accept the poor outcomes that are happening in your name? Can you accept rising income inequality happening in your name? And can you accept a progressively polarized nation? I don't think that's what we're about. That's why I think we are among the best people to start changing it. So can we get it done? In the language of another time, yes, we can. It'll happen if you stand up. So I'm going to try to get people moving a little bit. Would you please stand up if you think you can talk to your patients about how much money is coming out of their pockets? Somebody stand. Great. Would you please stand up if you think you can organize a healthcare hangout? Would you please stand up if you think you can organize a multidisciplinary team? Would you please stand up if you hate your EMR and want to change it? Would you please stand up if you hate the home health certification and plan of care, a document that means nothing to nobody? Here you are. Look to your left and look to your right. We've got us all on our feet. This is what we look like together. Now let's imagine what we can do when we stand up and revolt. Saul Alinsky, the great community organizer, quoting Hannibal, said, "Either I'll find a way or I'll make one." The time to make a way, the time to build a healthcare system for the United States, the time to build a movement for healthcare in the United States is now, and the people in this room are the people to get it done. Thank you.